In this video we'll discuss about part second of the breast carcinoma. So here in this video we'll discuss about the types of the breast carcinoma. So the types, the carcinoma, breast carcinoma can be divided into carcinoma in situ and invasive carcinoma. Now one thing is that majority of the breast carcinoma, they are adenocarcinomas. Around 95% are adenocarcinomas. We are talking about them only. So carcinoma in situ is further divided into DCIS and LCIS. That means ductal carcinoma in situ and uh, lobular carcinoma in situ, and further invasive carcinomas. Firstly, going to the ductal carcinomas. When we are talking about in situ carcinomas, that means that the myoepithelial cell layer is present. Okay, so the basement membrane, they are intact. So if you have the cells, so they are malignant cells present, but the basement membrane is intact. So ductal carcinoma in situ is a malignant proliferation of epithelial cells. Now these epithelial cells can originate from ducts as well as lobules. So why the name ductal carcinoma in situ is given? Because when they proliferate, they resemble small ducts. So you have your ducts and then you have your lobules. So these can arise from both ducts and lobules and be known as ductal carcinoma in situ. But if they resemble small ducts, they will be called as ductal carcinoma in situ. We'll talk about lobular carcinoma after this. So myoepithelial cells are preserved both in ductal carcinoma in situ as well as your in situ. When we're talking about, then the myoepithelial cells basement membrane is intact. Now one thing more important is that this can be detected on your mammography. That means when it is when the mammography was introduced, the DCIS, that incidence increased because this can be detected, and therefore the invasive carcinoma can be prevented. Now the subtypes of the ductal carcinoma in situ are two: comedo and non-comedo. So going to the comedo, there are two features which are very important in comedo type of your ductal carcinoma in situ. You have the cells which are present over here. This should be of high grade. Okay, they should be high grade nuclei should be present. Secondly, the central area should have necrosis, which is known as comedo necrosis. So this is a morphological pattern of the carcinomas. So this is morphology, how it is looking. So you should have high grade nuclei, you should have necrosis. This is known as comedo pattern in DCIS. Now going to the non-comedo pattern. Non-comedo pattern either lacks your high grade nuclei or the central necrosis. So what will be the subtypes? Apart from the special types in non-comedo can be cribriform DCIS. Now what is cribriform DCIS? Here you can see it is a cookie cutter shape pattern. So if you have your cells, these are your cells, it appears like somebody has taken a cookie cutter and cut these pieces out. So this is known as your cribriform pattern. This is the cribriform pattern, and this is the cookie cutter appearance. It is also present in non-comedo type. Then this is your micropapillary pattern, in which you can see these bulbous protrusions are present. Okay, but what is the difference is that these bulbous protrusions do not contain fibrovascular core. Because they do not contain any fibrovascular core, that means they are not true papillae. These are just micropapillae. They are just protrusions of the cells into the cavity. So this is your micropapillary pattern. Now going to the Paget's disease of the nipple. What is it? Now Paget's disease of the nipple is in this the patient presents with erythematous eruption over the nipple. Okay, patient has a scale crust. It appears as if the patient has eczema. Okay, because patient will present with pruritus, having a scale crust over the nipple. So but here what can happen is there is Paget's disease of nipple can present as a eczema also. So you can see what happens is there is a duct which is involved by DCIS. Okay, there are malignant cells over here. These malignant cells can go along the ductal system. Okay, this is the ductal system, and they can deposit just beneath the nipple in the your stratified squamous epithelium. So here the Paget cells are present. These Paget cells, they are malignant cells, but they have not crossed the basement membrane. Okay, they are not going through the basement membrane then involving. This is not the route. They are going through the ductal only. Through the ducts only they move upside and go to deposit in the stratified squamous epithelium. So malignant cells, which are the Paget cells, they extend from the DCIS. Also there can be invasive foci also present in the breast carcinoma. It is not only DCIS. Okay, the even, but these cells itself, they do not cross the basement membrane. So they can extend from DCIS within the ductal system via the lactiferous sinuses, go to the nipple skin, but do not cross the basement membrane. So what is the advantage of it is that you can readily detect them. Okay, when you are doing nipple biopsy or the patient presents with eczema, there is an exudate present, then you can do a cytological preparation of that exudate, and then you can see these cells itself. They do not decrease the prognosis of the person itself, because it is an invasive carcinoma that matters. So here in the microscopy, this is the microscopy, this part is the stratified squamous epithelium. You can see over here there are some cells which are bizarre looking. They have a high grade nuclei, the nuclear cytoplasmic, the NC ratio is high. Okay, so these cells, these are the Paget cells. Okay, these are the Paget cells present in the stratified squamous epithelium, that is in the nipple area. So the treatment of your DCIS, if you are talking about the treatment of DCIS, it can be prophylactic mastectomy can be done in the patient. This has less chances of reoccurrence. Second option is breast conservation surgery, which can be done. It has slightly more risk of reoccurrence, especially if the necrosis is present, if the tumor itself, the DCIS, was high grade. Okay, so it has more chance of reoccurrence. Now going to lobular carcinoma in situ. Now what is the difference between the ductal carcinoma and the lobular carcinoma is, now this again arises from ducts or lobules, but this is important that the lobular always grows in disc cohesive fashion. Okay, so it has a very disc cohesive fashion. That means one cell to another cell, they will not have any cohesion. Okay, there is no cohesion, they will separate out, because this is due to loss of EC adherent. EC adherent, due to loss of this, the cell goes to disc cohesion. Now what does EC adherent is, its role is in the normal body. Now normally it is a transmembrane protein which will help in cohesion of the cells. Okay, if you it will help in the cohesion of the cell, it will let the cells stick to each other. But when its loss is there, when there is CDH1 mutation, that gene which is responsible for EC adherent protein, it will lead to disc cohesive cells. The cells will be singly scattered. Okay, so in lobular carcinoma you have very particularly disc cohesive cell, even in the lobular carcinoma or lobular carcinoma in situ. So here you can see one thing more of this is the cells. If you see the cells, they are very round. In the morphology, the cells will be very uniform, they will be round, because they have been the EC adherent has been lost, therefore they get a rounded shape. So here you can in lobular carcinoma in situ, you will have a uniform population of cells with the round nuclei, very small nucleoli. Okay, this is a one appearance. Second appearance is signet ring cells can also be seen in the lobular carcinoma. Signet ring cells we will see in the later part of the video also. The nucleus is pushed to the periphery. Okay, now going to the invasive carcinomas. Now in the invasive carcinomas, firstly we will discuss about the gross, how if we receive the mastectomy specimen, what all changes can be there. Then we will discuss about the microscopic patterns. Okay, now firstly going to the gross picture. So gross picture, if you receive a mastectomy specimen, the itself the carcinoma part will be hard and irregular mass. Okay, when you cut through this tumor, it will have a characteristic grating sound. Why? Because of two things. Microcalcifications are present. Okay, because calcification can be present, and secondly there is a desmoplastic stroma present. The stroma has desmoplasia going on, and we will see I will show you what is desmoplastic stroma. Then larger carcinomas, they can invade the pectoralis muscle and can cause dimpling of the skin. Okay, in the mastectomy specimen you can see dimpling of the skin also, and retraction of the nipple can also be present. Now this is your appearance of the carcinoma. You can see over here it has a whitish appearance. Now going to the microscopy. Now in microscopy you will have firstly the invasive carcinomas, they have been divided mainly into two parts. You have your ductal carcinoma, no special type. Okay, and then you have certain special types. Okay, so when we are talking about this the which I am going to tell you the grading system, we are talking about the ductal carcinoma no special type. Okay, so here in ductal carcinoma no special type, you have a grading which is going on, that is your Bloom-Richardson grading. In this we study about three things. We have tubule formation of the glands of the carcinoma, you have nuclear pleomorphism and mitotic activity. So if you see over here, this is your ductal carcinoma ductal carcinoma no special type. So here certain tumors, they are forming tubules. Okay, then second is nuclear pleomorphism, how pleomorphic a cell is. Okay, how does the cell is pleomorphic. Okay, it differs from each other. Okay, it has high NC ratio, nucleoli. So these are for the nuclear pleomorphism. And last is your mitotic activity. So depending upon the percentage, like in tubule formation, if more than 75% of your tumor has tubules, it will be graded as 1. Okay, if it is 10 to 75%, it will be graded as 2. If it is less than 10%, it will be graded as 3. Then nuclear pleomorphism, if it is minimal, very less nuclear are different from each other, then 1, moderate 2, and severe 3. And then again mitotic activity, if mitotic activity is less than 5, then 1, 6 to 11 2, and more than 11 3. Now you will add these up. Okay, you will derive a number looking at the cells, then you will add this up. If you can see, if we add the minimal one, that comes to be 3. Okay, so 3 to 5 goes into well differentiated carcinomas, 6 to 7 goes to moderate, and 8 to 9 goes to severely, that is poorly differentiated carcinomas. This is about the ductal carcinoma in situ, ductal carcinoma, sorry, no special type. And the stroma surrounding, the stroma is the surrounding part. Okay, the surrounding part, this shows desmoplasia. This is a reaction to the tumor cells. The stroma goes into desmoplasia. This was the ductal carcinoma. Okay, now going to the lobular carcinoma. In lobular carcinoma, you have two patterns which you see. One is your Indian file pattern. So if you see in any office, how the files are arranged one above the other. So this is known as Indian file pattern. Here the tumors will be arranged one above the other. So you can see the straight lines of the tumor which are going. So this is known as the Indian file pattern of, this is seen in lobular carcinoma. This is one pattern because these are disc cohesive cells. These are arranged like this. Second is your signet pattern in lobular carcinoma, signet ring carcinoma. So here you can see the cells, the nuclei is pushed to the periphery like a ring. Okay, like a engagement ring, how it is. So the nucleus is pushed to the periphery. So this is known as signet ring carcinoma. This is also a morphological type which is seen in your lobular carcinoma. Other is special type is mucinous carcinoma. Now because it has mucin inside, and mucin is very gelatinous, so this tumor will not be hard to cut. It will be soft and rubbery and will have a appearance like grey blue gelatin. So here in the microscopy you can see the cells, they are just floating in the pools of mucin. This blue part is your mucin and the cells are just floating in the mucin. So this is again one morphological variant. Then you have your tubular carcinoma and papillary carcinoma. Now tubular carcinoma will just show very well differentiated tubules present. Okay, no sheets will be present, tubules and tubules will be present. In papillary carcinoma, you will have true papillae having fibrovascular core and lined by tumor cells. Then medullary carcinoma. Now medullary carcinoma is also a very interesting morphological variant. Here the two things are important, mainly two things are important. One is syncytium like growth of the tumor cells, and second is lymphoplasmacytic infiltrate which is present. Okay, syncytium like growth of very pleomorphic nuclei. Okay, they have very prominent nuclei, and secondly lymphoplasmacytic infiltrate. So here you can see, okay, here you can see the dark blue ones, these are the lymphoplasmacytic infiltrate. Okay, this is very characteristic. You can see over here, you can see over here, you can see over here, and these are the tumor cells. Okay, these tumor cells, they are so big in size. Okay, they even have very prominent nucleoli present. So this is again a characteristic of medullary carcinoma, and abundance of the mitotic figures. Okay, so these are the characteristic of your medullary carcinoma. This is the papillary carcinoma. You have a fibrovascular core going on, and then you have your cells. These are the papillary carcinoma of the breast. Other variants are also there, but for the undergraduates it's not important. The metaplastic, adenocystic, apocrine carcinoma. So these were the morphological types. Now going to the molecular subtypes. Now in the previous video also we discussed somewhat about the molecular subtypes and their relation to the familial breast carcinoma. So you can see in that video also. So what is molecular subtypes? Now depending upon the molecular, whatever the morphology is, the breast carcinoma can be divided into three parts. Okay, you have your first is ER positive and HER2 negative. Okay, this is done on IHC. Okay, so ER positive, that is estrogen receptor positive, and HER2 negative, this is known as luminal type. Then HER2 positive is named as HER2 enriched type. Then you have your ER negative and HER2 negative. This is known as basal like. Okay, and this is also known as triple negative. Why it is known as triple negative? Because there is one more marker which is done, which is PR. If that is also negative, then it is known as triple negative. So luminal is further divided into A and B. So A is known as low proliferation and B is known as high proliferation. This depends upon proliferation of the cells. If it is high, then it is known as high proliferation, low proliferation. Okay, rest these two are also high proliferation only. Only one is low proliferation, and that is good because this is the most common type. This is low proliferation. Now going to luminal A. So luminal A constitutes for around 40 to 55% of your carcinomas. It has low proliferation. This low proliferation is seen on Ki67. This is the marker which is done, and on that, if there is low proliferation, it is known as low proliferation. Certain subtypes are known to be the part of luminal A, like lobular, tubular, mucinous. Then luminal type B, this is around 10% of the carcinoma, the least of the carcinomas. Okay, this is associated with BRCA2 gene mutation, as we discussed in the previous video also. This is high proliferation. Then you have a HER2 positive. Okay, HER2 positive is around 20% of the carcinoma. Now these carcinomas, they are very high proliferation also, and they are very high grade also. But one thing good is they are response to the targeted therapy like trastuzumab. Okay, this is this inhibits HER2, and this is used. Then you have basal like and triple negative carcinomas. Now these triple negative carcinomas, they are again very high grade carcinomas. There is account for around 15% of the tumors. They have BRCA1 gene mutation, and especially medullary. Okay, medullary, if you see, they have very particularly, they are triple negative carcinomas. So this was all about the morphological subtypes and the molecular subtypes. Do ask your queries in the comment box regarding this topic. Thanks for watching this video.